Hey everyone, so we're going to get started. So thank you so much for taking time out of your day to join me today. My name is Dr. Arielle Cantor, and I'm one of the fertility physicians at Trio Fertility. And I'm excited to be able to answer any questions that you have today about fertility, infertility, or reproductive endocrinology. So you can start inputting questions into the question and answer box. I won't be able to give very specific recommendations based on your exact history, but I'm happy to try my best to answer any questions that you have. So please feel free to ask me anything, and I will do my best to try to answer. The first question that I see here is, when can I start IVF after a miscarriage or pregnancy loss? That is a really good question, and it depends a little bit on the specific scenario. So you always want to confirm after the pregnancy loss that all the tissue has actually passed from the uterus. So you just want to make sure that there's not any what we call retained products, and the cavity is clear after. You also want to make sure that the pregnancy hormone has gone back to negative as well. We do blood work to make sure that the serum beta HCG or pregnancy levels are back to negative. And we also traditionally recommend doing an ultrasound or a sonohystogram to look at the inside of the uterus as well to make sure that there's nothing in the actual uterus that can preclude another pregnancy. Usually we recommend also for your menstrual cycles to go back to their regular rhythm. Once, we verified all of those things, you're most likely able to, go back into treatment. Also, it depends a little bit on, the reason for the pregnancy loss. So, if you've had one pregnancy loss or if you've had a history of recurrent pregnancy loss, then the situation can be a little bit different. So sometimes we may want to do some additional investigations before going into an IVF cycle. So this I would discuss in a little bit more detail with your doctor based on your exact situation. But traditionally, we like to just ensure that, you're back to regular cycling, the uterus looks okay, and your hormone levels are back to their baseline. And then traditionally, you're able to get back into treatment. Hope that answers the question there. Another question that we have is, what kind of exercise can I do after an IVF transfer? After doing an embryo transfer, so that's a good question. So it does depend a little bit if you had a fresh embryo transfer or a frozen embryo transfer, because the body is stimulated a little bit differently in both of these scenarios. So after a fresh embryo transfer, that would be a few days after you actually had your egg retrieval. So your ovaries are quite stimulated. They're also enlarged. So there is a theoretic risk if you do any forms of strenuous exercise that the ovary can potentially twist on itself. So usually in those cases, we recommend not to do anything strenuous like running, HIIT exercises, anything that can really have put your ovaries at risk of what we call ovarian torsion or the ovaries twisting on itself. So, if you're having a fresh embryo transfer, walking is totally fine. Lifting, small weights is totally fine, but you don't want to do anything that can put additional stress that could lead to twisting of the ovary. And I would also avoid any, abdominal work that can lead to, movement within the ovaries that are stimulated. If you're doing a frozen embryo transfer, usually the ovaries are not overstimulated in that context. We're usually just preparing the lining of the uterus to prepare the body for an embryo. So in that particular case, it's a little bit different. I usually don't impose significant restrictions on my patients undergoing a frozen embryo transfer cycle, but I do, tell them to be cautious leading up to, the pregnancy test itself, just to make sure that everything is okay. But truly after a frozen embryo transfer cycle, no major limitations in terms of the ability to, do different movements. It's really just after a fresh embryo transfer cycle where the ovaries are quite stimulated that you want to be cautious. Another question that we have is, how long after fibroid surgery can I go do IVF? So that's a really good question, and it depends a little bit on the type of fibroid and the type of surgery that you have. Fibroids are smooth muscle growths of the uterus, and they can occur in different locations. So you can have a fibroid that's in the muscle wall of the uterus. This is called an intramural fibroid. You can have fibroids that are located on the outside of the uterus. These are called subserosal fibroids. And you can have also fibroids that are located in the actual cavity of the uterus. So these are the ones that are called submucosal fibroids. And often these are the ones that we recommend removing before moving forward with an embryo transfer. After fibroid surgery, we do want to confirm that the cavity has gone back to its usual or normal configuration. So we want to make sure that the fibroid has been completely removed. And sometimes what can happen is if it's a very large fibroid, the surgery potentially might need to be a staged procedure. So sometimes, you can remove part of the fibroid and there's still some additional fibroid that needs to be removed. However, In other cases, it's a small fibroid, you're able to remove it in one surgery, and then you confirm on either repeat hysteroscopy or on a sonohystogram that the cavity itself is back to normal. If the uterine cavity looks back to normal and it was just a small fibroid that needed to be removed, usually there's not significant delays between your surgery and going back to IVF. I traditionally tell my patients, let's allow your body to have at least one menstrual period before we go into an IVF cycle. If you've had quite extensive fibroid surgery, so let's say they had to go through your abdomen and do what we call an abdominal myomectomy and remove a large fibroid, or if they had to do a deeper dissection and they're going through the layers of the uterus to remove a large fibroid, that is a little bit of a different scenario. We do in those cases want to give the uterus a little bit more time to heal. So truly it depends, how large the fibroid is, where the fibroid is located, how extensive the dissection of the fibroid was. Traditionally, if it's done hysteroscopically or through a camera through the vagina, traditionally we don't have significant delays between that and moving forward with IVF. But if it was a big abdominal surgery, a large fibroid that needed to be removed, that was, they had to dissect into the layers of the uterus. Usually we want to give more time for the uterus itself to heal. I would say approximately, sometimes even 3 to 6 months. So it depends once again on, the size of the fibroid, the location of the fibroid, in terms of, how long you should wait, let your uterus recover before moving forward with treatment. Hope that answers the question there. So another question that we have here, I have PCOS, what are my options? PCOS, or polycystic ovarian syndrome, is a clinical disorder that's characterized by a few different things, and you don't necessarily have to have all the clinical criteria to have the syndrome. So one of the most common things with PCOS is irregular cycles. Another thing that we see with PCOS is either clinical signs or biochemical signs. So when we do blood work, of increased male hormone. So every person with eggs has a mix of both female and male hormone, but in PCOS, the imbalance of the hormone levels can be a little bit dysregulated. So some people with PCOS may have elevations in their androgen levels or male hormone levels. And another thing that we might see is that the ovaries are more enlarged on ultrasound, and the follicles, or the small sacs that contain the eggs, are peripherally distributed. If you do have cycle irregularity, then that would definitely be a reason why you would want to come see a fertility specialist to help if you're trying to conceive. Because if your cycles are irregular, that means that you're not necessarily ovulating or releasing an egg on a consistent basis. And therefore, it can be really hard to time your intercourse appropriately for pregnancy. So one of the most common things that I see in my practice are, patients coming in with PCOS, with irregular cycles and wanting to family plan. And we do have medications that we can give to induce ovulation. There are oral or injectable medications that can be done to help people have a regular menstrual cycle, to produce one follicle or potentially more follicles, so that they can release an egg consistently and then either time their intercourse appropriately or potentially do further fertility treatments such as an insemination or an IUI. Beyond ovulation induction, there are more, intensive fertility treatments that can also be employed in PCOS. So some people with PCOS have a really high ovarian reserve or egg count. And because of that, some people might want to take advantage of that and go through more, intensive treatments such as IVF, whereby we take egg and sperm from the body and get ideally a cohort of embryos that we can put back for pregnancy as well. So some people with PCOS may warrant other fertility treatment beyond just ovulation induction, which is our conservative treatment. In terms of PCOS in general as well, I've spoken a little bit about, family planning or fertility options. I always speak about other, lifestyle options with my patients as well. So not all patients with PCOS, but, a large proportion of patients with PCOS have other metabolic disturbances as well, which predispose them to certain, disorders potentially down the line, like cardiovascular disease, metabolic disturbances like diabetes or gestational diabetes in pregnancy. So, it's really important that we, discuss lifestyle modification, keeping, diet and exercise recommendations as well. For my patients with PCOS that also have very irregular cycles, I also recommend to have, withdrawal bleeds at least a few times a year, such that we don't want the lining of the uterus to get too thick, because over time that can lead to cellular changes in the lining of the uterus as well. So There are, things to discuss with PCOS beyond just attempting pregnancy and fertility. For patients with PCOS and irregular cycles that aren't looking to family plan, there are options also to help with cycle regulation too, whether that be with a birth control pill or an IUD. So, PCOS is definitely a very broad topic. There's numerous options to help with pregnancy attempts, whether that be through ovulation induction or more intensive fertility treatments. There's options to help with cycle regulation if you're not hoping for pregnancy. And then we always talk about, lifestyle options overall as well. So, depending on what your target is in the context of PCOS, there's definitely a variety of options available to you. I always, talk to my patients with PCOS that it's always good to see, a fertility physician or a reproductive provider early on, especially if your cycles are irregular, so that we can discuss how to optimize time to pregnancy for you. The next question, what are treatment options for sperm morphology, or I'm assuming that means 0%. 0% normal sperm morphology, is IUI an option? So that's a really good question. So when we're looking at a semen analysis, there's a few things that we look at. The first thing that I traditionally look at is the volume of the sample. So how much is in the actual sample? Is it an appropriate collected sample? The next thing I look at is, the concentration of sperm in the sample. So how much sperm is actually there? Then I look at the motility or the movement of the sperm, and I look at the whole sample overall, and then specifically the sperm that are called progressive or swimming forward. And then finally, I look at morphology. So morphology is what the sperm look like. We actually have low expectation of the overall sperm sample. So traditionally, in terms of what's considered normal on an average sample, is only about 4% of the sample to have normal sperm morphology. So overall, that means about 96% of the sperm can have, an atypical appearance. Now, in terms of predictions of, success with a sample that has a poor sperm morphology, typically I put more emphasis on the concentration of sperm and the motility of the sperm as being predictive for success of treatment. I have had patients that have had a poor sperm morphology and have had success, and specifically whether that be with IUI or IVF. So even with poor sperm morphology, assuming there's an appropriate concentration and appropriate sperm motility, I would say having poor morphology on its own is not a reason why you cannot do an IUI or an insemination cycle. There's other criteria that can be looked at in sperm as well. So there's an entity called DFI, or DNA fragmentation. This is a special test that looks at the quality of the sperm or the amount of DNA damage in the sperm sample. This speaks a little bit more to the quality of that sample. So that can also, point us in a direction as to whether, this is of appropriate quality sperm to move forward with maybe an insemination, or if IVF would be a better option. But truly 0% sperm morphology on its own will not preclude me from putting a couple through an insemination cycle, assuming that IUI otherwise makes sense for them as a starting point. In terms of potentially optimizing sperm morphology, and before I talk about that, one thing that I do want to emphasize is that sperm from production to ejaculation actually is about a 3-month process. And it's important to know never to put full judgment on one semen analysis alone. So, let's say you do have a semen analysis and there's the concentration or the motility or the morphology is not, exactly where we want it to be. It doesn't mean that there's certain things that we can't do to improve upon the sample itself. And truly, once again, I never really make full, judgment on sperm based on one analysis alone. So, if there were maybe, slight morphology issues, I always would say, we can repeat the sample. Or if, things are otherwise normal and we are going into an IUI, we can actually assess a sperm at the time of IUI as well, to see, was this just, a one-off with this particular sample? Is this a consistent finding? When we do an insemination cycle, the lab actually takes sperm and washes it such that we get the best quality sperm in the sample that we can put back in for the actual insemination. There is the potential that overall it can still be an appropriate sample. For my patients that have motility abnormalities, we do have some antioxidants that can be employed to try to improve the sperm quality overall. These supplements don't traditionally target morphology on its own, but overall antioxidant supplementation can help improve sperm quality overall. So that can also be something that can be employed. To summarize, in terms of options for sperm morphology, IUI definitely is still an option. I wouldn't put full judgment on one semen analysis alone. So if there's one analysis that has a poor morphology, it doesn't mean that morphology is always poor. Assuming concentration and the motility is good, IUI is definitely something that can be given a go. Another question that we have here is how many embryos do you transfer and how do you grade them? So this is a great question and it depends on a few different criteria. So in terms of embryo transfer, we recommend putting in one embryo at a time. Ideally, our goal is to optimize pregnancy in the safest way possible. So we know that a multiple pregnancy comes with some additional risk for both the person carrying the pregnancy as well as the potential babies. So ideally, our goal is to get someone pregnant with one baby. How many embryos we're actually able to transfer, it also depends on a few different criteria. So in Ontario, the government actually provides some funding for fertility treatment. So IVF is covered for one cycle as long as the person providing the eggs is less than 43 years of age. And the government itself actually mandates how many embryos can be put in a funded cycle depending on someone's age. So the younger someone is, the more restricted it is. So up to age 35, we're really only able to put back one embryo at a time. And then as someone gets older, there is a possibility of potentially putting in more than one embryo, depending on the stage of development of the embryo. And there are certain exceptions to this as well, depending on if there's been failed embryo transfers before as well. So if someone has failed numerous embryo transfers, then there is a possibility of potentially doing a double embryo transfer. We recommend one embryo transfer. There are cases where we will put back two embryos, depending on if it's a funded or private cycle, how old the person is, and the clinical context if they have failed embryo transfers before. The second portion of this question. So we grade embryos based on their stage of development and on their morphology. Once we assess it that way, there's also the option of doing genetic screening, which is not necessarily how we grade embryos, but it's a step beyond that in terms of assessing the genetics of the embryo itself. But in terms of embryo grading, basically we look at the inside of the embryo, what we call the inner cell mass. We look at the outer layer of the embryo, which is called the trophectoderm. And then we also look at the degree of expansion of the embryo itself. So we actually have a scoring system of letters and numbers whereby we look at the different components of the embryo itself. And that really gives us some information in terms of, the development of that embryo. Morphologic grading does not necessarily dictate outcome per se. You could have an embryo that's a little bit less developed and still have a good chance of pregnancy and vice versa. Morphologic grading of an embryo doesn't necessarily correlate with the genetics of the embryo either. We do have, a system whereby we describe the embryo based on how expanded and how developed it is and how tight the cells on the inside and the outside are packed to give us a description of, what the embryo looks like. And this is done for blastocysts. So these are day 5 and day 6 embryos. Sometimes we look at embryos that are a little bit earlier on in development, and usually these embryos are just assessed by the number of cells that they have. So usually on day 3 of embryo development, we expect an embryo to have about 8 to 10 cells, and this tells us that it's at an appropriate stage of development. The next question, what is the evidence on DHEA supplement for those with diminished ovarian reserve? Does DHEA increase AMH level or antral follicle count? So this is a really great question. So DHEA is a male precursor hormone that is sometimes used to help with what we call ovarian responsiveness. So this is a supplement that is definitely not used routinely, but it can be employed in certain cases with the goal of ultimately trying to increase the responsiveness of the ovaries. So in terms of DHEA increasing ovarian reserve, or what we call egg number, and that's assessed by the antral follicle count or the AMH level. So, just as some background. So, women were designed, I would say, not in the smartest way. So we're born with all the eggs that we're ever going to have. And as we get older, our egg quantity and our egg quality change over time. And I wish I had a medication that could significantly increase our egg number. But unfortunately, we have a certain protocol strategies that we can, employ to try to get different cycle outcomes, to try to improve our overall response. But we really don't have any great treatment to increase what we're working with. So, if I have a patient who has diminished ovarian reserve or a low AMH, a low follicle count, in those cases, we do talk about, either androgen priming or giving DHEA to potentially improve the cycle outcome, improve the responsiveness of the ovaries. But DHEA itself is not going to increase your egg number. It's not going to increase the AMH that you have. Unfortunately, we don't have any medication to increase your AMH, and we can't make more follicles. We can try to work to increase the responsiveness of what you do have at baseline, potentially try to optimize the quality of the eggs that you do have, but we don't have a good medication or treatment to increase your AMH or increase your follicle number. In terms of the evidence surrounding DHEA, it also speaks to the length of time on DHEA. So traditionally, as per the studies, the recommendation is to be on DHEA for a certain period of time to see some impact. So traditionally, at least 8 weeks, which is, depending on your fertility timeline, can be a long period of time. An alternative to supplementing with DHEA, especially in those that don't want to wait, 2 to 3 months to have that supplementation period completed. Sometimes we do something called androgen priming, or preparing the ovaries before their IVF stimulation, potentially, or other treatment with some androgen as well that doesn't require that length of time. So that's also an option. There is some evidence for DHEA in terms of helping with ovarian responsiveness. It's not something that I use first line in my patients. It's definitely something that we talk about when it's applicable for specific cases, but unfortunately, it cannot increase AMH or follicle number. Another question that I have a child from IUI, or intrauterine insemination. I am now 41 and have been trying for 3 months. How long should I wait to have intervention? So this is a really great question. If you required IUI for your first child, what was the reason for that? We just spoke about, the impact of age on fertility. Given that you're 41 and have been trying for 3 months, it's definitely something that would warrant you speaking with a fertility physician. If you're less than 35 and have been trying for about a year, you can speak to your fertility doctor. If you're more than 35 and have been trying for about 6 months, it's a good idea to speak to a fertility doctor. But if you have any reasons such as irregular cycles or any, specific cases that could, interfere with fertility, you might want to speak to someone sooner. Having had an IUI before, is there any, possible baseline male factor, or, what was the reason that an IUI was needed previously? Fertility declines, significantly, even over 3 to 6 months at this stage. Trying to optimize outcomes, chat with your fertility doctor, do some, updated investigations, see what is happening from an ovarian reserve or egg number perspective, maybe check in on your partner's sperm as well, repeat a sonohystogram to look at the uterus and the fallopian tubes, and then potentially considering intervention in terms of a family planning perspective. How many more children do you potentially want as well? If the answer is more than one, be interventional sooner rather than later. From a infertility, we always want to, take advantage of where we are right now, start a conversation, undergo some testing. It'll be a personal decision whether or not you want to be more interventional. This is one of my last questions that I have. I'm happy to answer any more that come in. But during an IUI, there is no evidence to show that an egg is or has been released, even with ovulation induction. How sure is it that ovulation stimulation timing is right and an egg has been released to ensure that you have a higher chance of success during IUI? So this is a great question. When we're doing an IUI cycle, we do something called cycle monitoring. So basically, we're doing blood work and ultrasound to assess someone's, menstrual cycle, either naturally or on medication. We're monitoring the growth of follicles, the rise in hormone levels, and we're looking at the endometrial lining. This is a medication to ensure that there's ovulation. So the mechanism of action of the medication increases one of your hormones called LH, and it leads to triggering of the release of an egg from that follicle. So that is truly ovulation. Now, in terms of, confirming that, there are some possible tests that can be done. So for example, to prove that you have actually ovulated, you can theoretically do a progesterone level about a week or so later after ovulation. And if your progesterone level rises, that suggests that there has been ovulation. Once your follicle releases an egg, the follicle itself actually turns into a cystic structure that will resolve over time. That cystic structure is called a corpus luteum, and it actually secretes progesterone. So a progesterone rise in the latter part of your cycle is actually predictive of ovulation. Beyond that, some people, are starting to show signs of ovulating on their own. So we start to see on blood work that, that rise in LH that we're already witnessing, and, changes in the estrogen levels accordingly. So we can start to see signs of that. And I would say, the chance of not responding to a trigger medication, if we are giving that trigger, is quite unlikely. As if you've been given a trigger the goal of that medication is to ensure that there is going to be ovulation. Now, based on the timing of when the trigger is given, that's how we know how to time the IUI procedures. The egg actually stays alive in the reproductive tract for about 24 hours, but sperm can actually stay alive for about 72 hours. So, when we're taking advantage of our cycle monitoring, we're really picking a time that we think is appropriate based on when we trigger the ovulation and when we think the egg is going to be released in terms of, when to actually time the procedure around that. We don't always check progesterone levels in the latter part of a cycle because when we give the trigger medication, we assume that it has worked in terms of stimulating ovulation. But if this is something that you're ever worried about, you can theoretically do a progesterone level in the later part of your cycle just to ensure that there's been an appropriate progesterone rise. So I hope that answers your question. Are there any other questions or comments that anyone else has? I'm happy to go through anything else. If there aren't any other questions, I really hope that today was helpful. I hope I was able to answer any questions that you had. It was really my pleasure to speak with you guys today, and I really hope that everyone's doing well in their fertility journey. If you have any questions beyond today or any concerns, you will get a follow-up email, and you can direct them to our clinic. And otherwise, I hope you guys have a great afternoon. Thank you for taking the time out of your day to speak with me. Take care.